Welcome everyone. Good morning. Welcome to today's Community of Practice session. We're happy to have you here, have a full house. My name is Danny Hansen. I'll be your Zoom moderator for this COP. We're so glad you could join us today. Before we start, we want to go over a few housekeeping reminders to ensure a smooth session. So if we want to remind everyone that we are recording this session, so please keep your microphone muted unless you're speaking. To protect everyone's privacy, please avoid sharing any personal information in the chat. And if you'd like to preserve your anonymity, feel free to turn off your video camera. Also, as you can see on the screen, we have some audio and internet tips. As we mentioned, make sure that you have the right microphone selected and the same speakers if you can't hear us. And also, if you're experiencing some internet issues, sometimes turning off the camera helps out with the internet connection stability. Also, one quick reminder before we begin for the CEUs and certificates. If you are attending for CEUs or a certificate, it is essential to stay for the entire session and complete the evaluation at the end. We're also saving the attendance that we have on Zoom. So please just remember that. We're going to mention it at the end again. With that, I'm going to hand it over to Maggie, who's going to go over the objectives and get the session going. Thank you.
Hi, everyone. My name is Maggie Ringy, and I am a project manager with Harbor Care. Thank you for joining us today. Our objectives for the community of practice today are that participants will learn a foundational knowledge about medications for addiction treatment, how medications for addiction treatment stigma manifests in recovery communities, and how to support medications for addiction treatment as a recovery pathway. We are then, I actually wanted to also talk a little bit about language and how that is important when it comes to medication-assisted treatment or medication for addiction treatment. Next slide. Medication-assisted treatment, you may also hear it as MAT, includes opioid treatment programs, behavioral therapy medications to treat substance use disorders. We want to be aware of the language that we're using when it comes to MAT and ensure that we are understanding that there is a stigma to that language and to the language that we use, and we can use different language to avoid that stigma. So other alternatives we can use are medication treatment for opioid use disorder, medications for OUD, opioid agonist therapy, pharmacotherapy, medication for a substance use disorder, and medication for addiction treatment. The term medication-assisted treatment implies that this is a supplemental or temporary treatment, and it's not necessarily the case. In a lot of medications, specifically psychiatric medications, those are critical tools. They are central to the treatment, and they are something that a person will be on for ostensibly forever. So the usage of the language that we are using in this case, we want to make sure that we're treating it with respect and not stigmatizing anyone that uses this as their pathway. So next, our speakers today are Jennifer Smith, graduated from Michigan State University's College of Osteopathic Medicine. She's dually board certified in addiction medicine and family medicine, is a fellow of the American Society of Addiction Medicine, ASAM, and has been providing substance use disorder treatment for 15 years as part of her primary care practice. In May 2024, she transitioned to full-time addiction medicine as the Associate Medical Director of the Comprehensive Addiction Medicine Program at Memorial Hospital, while continuing to provide primary care to those patients. Dr. Smith enjoys spending time with her 5 children and hiking in the White Mountains. Angelique McCutt, certified medical assistant, has worked in primary and care and addiction medicine for 8 years. As part of the addiction medicine program, Angelique performs intakes for new patients, rooms patients, and helps coordinate care with therapists, peer support, detox units, and mental health care. Angelique consults for patients with SUD in the emergency department, provides harm reduction supplies, and serves as an advocate for patients with SUD in the community. Angelique enjoys spending her free time with family and friends. She loves dirt biking and spending time outdoors. Troy Barnes is a recovery coach at White Horse Recovery in North Conway with 7 years in recovery. This year, he earned his CRSW and has recently been active with Peer Recovery Support Services Planning Committee, which helps develop COP trainings that like the one you're in right now. Decades of drug abuse and addiction led to homelessness and prison and nearly cost Troy his life. Despite these setbacks, he has managed to find sobriety and rebuild his life, forging a path forward while helping others with their own battles with addiction. Troy is wasting no time and is making up for years lost and a life nearly extinguished from addiction. And so now I will, before I hand it over to Dr. Smith and Angelique, we are going to have 2 Q&A sessions at the end of each presentation. And so please hold your questions until the end and feel free to type them in the chat if you want to keep it in mind. And you can also direct message it to me and I'll make sure to address it to the right person during our Q&A sessions. And I'll turn it right over to Dr. Smith and Angelique.
Great, thank you. Thanks for everyone for coming. So like I said, my name is Jen. I am primary care trained. I've been doing medicine for about 20 years and doing addiction as part of that for probably about 15 now. And then went on to get board certified in addiction medicine and in May transitioned to doing that full time now. So, and this is Angelique, who's my certified medical assistant. We've been working together for about 6 years or more now. So, yeah. So you can advance the slide, please. So this is our newly kind of named comprehensive addiction medicine program. This is something that, so we're part of Maine Health, which is a Maine-based out of Portland, but some of the smaller hospitals are creating these comprehensive addiction medicine hubs. We're taking referrals from the community really for any substance use disorder, although the majority is opiates and alcohol. We have a program called New Life that treats patients that are pregnant and during their postpartum period. We have behavioral health on site consisting of psychiatric nurse practitioners, which we have 3 full-time and 2 half-time right now, which is really great. They see both our patients here and patients from the community. We have open slots that we're interviewing for right now for counselors, and hopefully we'll have that in place in the next couple months. As part of our program, we also do primary care for any of our patients that are in our program. We do screening for STDs, HIV, Hep C, vaccinations, kind of all routine primary care services. And then I also do treatment for hepatitis C if needed. And then we also coordinate with therapists in the community. We work closely with our peer support specialists in the community. And we are trying to offer some more on-site recovery meetings like Smart Recovery. We also provide some harm reductions services and supplies, and just recently have been kind of consulting with inpatients in the emergency room. Our primary care is on the hospital site, so there's primary care, nursing home, ED, and inpatient unit kind of all on one campus, so that makes it easy for us to coordinate some of those services. Next slide. I just kind of put in a little bit of definitions about opioid use disorder, which I think most of you are probably familiar with. You know, the newer model stating that this is really a chronic medical condition and it's something that people tend to deal with for the rest of their life, whether they are actively using opiates or not, and that opioid use, does to make changes to the brain. So there are some abnormal functions in some of the brain centers, and that can cause people to have strong and difficult to resist urges to continue using opioid drugs. So stopping using opioids is a first step to improving quality of life, but most people are unable to continue in that pattern without the help of medications. And we're going to talk about some of the things we have to offer. And there are many people that go to the hospital or to detox units that might come off opioids. And if they return home without a medication, that does put them at increased risk of relapse and possibly overdose. Next slide. So most of our guidelines that we get are from the American Society of Addiction Medicine. That's kind of the governing board for providers in addiction medicine. They put out these kind of long list of guidelines, but these were ones that they updated in the past year or so. And basically it's stating that we should be doing a real comprehensive assessment to anyone that's coming in to seek care. Meaning that we're looking at their behavioral health needs, other health needs, and things like that. But if we're thinking of starting a medication for opioid use disorder, that full evaluation should not delay us starting medications because they can be life-saving. And that concurrent use of other illicit substances, cannabis, stimulants, alcohol, whatever it might be, shouldn't be a reason to withhold or suspend medications for opioid use disorder. I'm going to use the MOUD acronym today, meaning medications used for opioid use disorder, and that there are really no recommended time limits for treatment with these medications, and that we should be addressing their psychological needs and referring for treatment, including maybe medication management and counseling. But if a patient declines to do that, or if we just don't have available services for that, again, that shouldn't delay medication management of their opioid use disorder. That really both office-based or emergency room or home-based medication starts are considered safe when using buprenorphine, and that withdrawal management should be a first step, but is not really a long-term treatment for opioid use disorder. Next slide. So I think that, we'll talk a little bit about stigma and abstinence and therapy-based treatment. So what the American Society of Addiction Medicine puts out for a statement regarding therapy is that most patients with opioid use disorder, that the use of medications with psychosocial treatment is superior to just psychosocial treatment on its own, and the combination of both things is the recommended standard of care. Working in a rural area, that's not always available to our patients, so we definitely try to hook people up with community services while also having them on medications. Some of the benefits of being on medications for opioid use disorder is that the psychological treatment does take time to be more effective. Medications work quickly to help reduce cravings and reduce the risk of overdose and death. And it is much easier to work towards recovery, with a therapist or in group if you don't have to cope with those strong cravings. And there's multiple medical studies that show that both methadone and buprenorphine reduce rates of illicit opioid use, reduce mortality, risk of infections, and improve retention and treatment. We had a little bit of a discussion about abstinence-based treatment yesterday, and I did just quickly today pulled up like 2 articles so these are like 2 big journal articles that compared abstinence-based treatment against medications for opioid use disorder. And really, this one is from the Journal of the American Medical Association, and their results were only treatment with buprenorphine or methadone was associated with a reduced risk of overdose, both in a 3 and 12-month follow-up. And treatment with buprenorphine or methadone was associated with a reduction in serious opioid-related acute care use, so probably like emergency room visits and things like that. And their final statement was that methadone and buprenorphine were associated with reduced overdose and opioid-related morbidity, and it should be used as a first-line treatment for opioid use disorder. And the other article was out of Canada, and pretty much was consistent with the same sorts of things. They did say that methadone has higher retention rates than buprenorphine, and buprenorphine has a lower risk of overdose. And for all patient groups, that physicians should be recommended methadone or buprenorphine over abstinence-based treatment. And that was level 1 evidence. So when we look at medical studies, when we call them a level 1, that means that it has the most kind of scientific studies to back up the evidence. So I know that everyone has kind of their different pathway, and abstinence is certainly one way, but with opioid use disorder right now, and medications do have a lot of benefits and reduce patients' risks of overdose and death. Next slide. So this is what we currently have available, that's FDA approved to treat opioid use disorder. I'm sure you guys are most familiar with methadone. It's been around for a long time. Naltrexone is the pill form, and Vivitrol is the injectable form of naltrexone. And then buprenorphine comes in a lot of different formulations. Those are some of the brand names. They're available in films, tablets, injectables, and we'll talk in a little bit more detail about each of those. Next slide. So methadone is kind of the first one we'll talk a little bit about. I pulled these pictures because I think that this is what really helps me talk to patients about how these medications work. So the kind of the blue Pac-Man looking thing up at the top of the screen is what we call an opioid receptor. Those are what's in your brain. So if you use any opioid like, fentanyl or oxycodone or heroin, that's where this binds to. That's what causes, the high, the positive effects. It's also when it comes off is what causes cravings and withdrawal. So all of these medications will be acting on these opioid receptors in all a little bit different ways. Methadone is what we call a full opioid receptor agonist. That means that it binds to the opioid receptor just like other opioids do. So when it's there, it kind of satisfies, obviously would stop withdrawal because you're satisfying the receptor, and will stop cravings. And if you use while you have methadone on board, then your other opioid doesn't have a place to go. So it kind of eliminates the high from other opioids. So the goods with methadone, it's been around for a long time. We have lots of studies proving its efficacy. Again, it strongly activates the opioid receptors. So you're reducing withdrawals, cravings, and kind of blocking high if someone does use while they're on methadone. There's a lot of studies proving that patients that take methadone use less opioids, have fewer medical problems, and some better social functioning. It's a much more structured program for people that might need that sort of encouragement, and some of the clinics offer therapy as part of their program. The downsides is that it can still only be done at a methadone clinic, which for us, the closest is probably an hour away. So for most of our patients, it's not really a doable thing just because of the daily visits and the far travel. If not taken daily, if you miss a dose, it can cause withdrawal because, again, once you remove that full agonist from the opioid receptor, that's when withdrawal starts to happen. It is a fairly potent medication. It does have a lot of drug interactions. It does potentially have some changes to patients' EKGs. So there are some monitoring things that we have to do. And certainly, if you take it with other sedating medications, like maybe alcohol or benzodiazepines, there is a risk for overdose while taking it. And there's some of the listed common side effects, which you'll see are really common for all of them. Oh no. What? Oh. Sorry, my computer shut down. I hope that it didn't interrupt where I'm at. So the next slide, please. So naltrexone might be a medication that you're a little bit less familiar with. It is one that we've been using for alcohol use disorder for a long time, and more newly for opioid use disorder. It's a little bit different in how it acts. It is not an opioid or opioid-like at all. It actually blocks the opioid receptor. So if you have this on board and you do use an opioid, it kind of blocks the high again. So again, can decrease cravings. The nice thing about it has no abuse potential at all. You could start this medication, you could stop the medication. You're not going to get any withdrawal side effects from coming on or off of it. And if it is a medication that you like, it's available in a monthly injection called Vivitrol that we can do here at the hospital. I would have to say I use this medication much more for alcohol than I do for opioid use disorder. I personally don't know that it's as effective as the other medications we have for opioid use disorder. And the big downside is you cannot start this medication until you've had no opioids in your system for 7 to 10 days. So I don't get the chance to see many patients in that, that are at that point in time in their life. If they were at a detox unit, that might be a good place to start something like this. The other thing is it does block opioid painkillers. So if you did have an accident or needed some sort of surgery, we can definitely control your pain, but we might have to use a little bit higher dose to override the naltrexone. I don't really have anyone using the injection right now. I have on and off, again, more for alcohol than anything else. I think it's pretty well. I don't get many complaints about it, I guess. Taking the pill form, I do get a little bit of complaints about nausea sometimes, but it's usually pretty well tolerated. And obviously, if you're not taking it, there's risk of overdose if it's not on board. Kind of the clinical guideline about naltrexone is that it's just not super effective, especially in the pill form because of compliance. I mean, you really have to commit to taking this every single day. So it's something that we use in the right population, but it's not something I use a ton of. And again, I probably use it more for alcohol for anything else. Next slide. So buprenorphine comes in a lot of different names. We'll list some of them in a minute. You guys are probably all fairly familiar with this. It's been around for a long time. The nice thing about buprenorphine, it's what we call a partial opioid receptor agonist. So when you saw the picture of methadone, it was kind of fully sitting on that opioid receptor. And buprenorphine, I kind of explained to patients, kind of half sits there. So it satisfies it, but it's not there fully. The nice part about that is that it's a medication you can take for a long time at the same dose without building up tolerance to it, versus if someone was taking a pain medication, because it's a full agonist over time, you would build up tolerance. In buprenorphine, that doesn't happen because of the partial receptor agonist. So it definitely helps eliminate withdrawal symptoms and cravings, but because it's only partially binding, it's a little bit safer to take long-term with fewer side effects. Now it can be prescribed by any provider with a DEA license. So it used to be a few years ago that we had to have special training and a special DEA number to prescribe this, and they've gotten rid of all of that. So pretty much any provider now that writes prescriptions can write for it. They might not feel comfortable or feel like they have the training, but it's possible. It really protects people from overdosing. So like I said, if this is partially bind to that opioid receptor and you're using, let's say fentanyl on top of it, it's kind of blocking both from the high and blocking someone from overdosing. And it's available in a lot of different forms. So everything orally is taken what's called sublingual. So it actually sits on the floor of your mouth and gets absorbed that way. If people swallow it and it goes into their stomach, it's deactivated and doesn't work very well. It comes that way both in films and tablets. And then we also have some injectable preparations in weekly and monthly. Usually well covered by insurance. And if not, it's available fairly inexpensively now that it's generic. Some of the downsides is if you start taking this while you have other opioids on board, it can put you into some withdrawal. So you need to start feeling withdrawal symptoms a little bit before you initiate it. And we're going to talk about different ways that we start people on buprenorphine in the office. Usually pretty well tolerated. Maybe some nausea or constipation are the biggest complaints. Overdose can occur if mixed with alcohol or benzodiazepines, but that is really rare. And I haven't seen it at all, but I've only heard reports mixed with really high doses of benzodiazepines. But one of the downsides is because it is partially acting that opioid receptor, when it comes off of it, it can cause some withdrawal symptoms. And that sometimes makes it hard for people to stop taking this when they feel like they want to. Next slide. So this is kind of all the different products that are available. Some of these in parentheses are brand names, Subutex, Suboxone. We now have Brixadi and Sublocade at the hospital that we give in our injection or infusion clinic. Brixadi, like I said, is available both weekly. We haven't been doing that as much just because we have to schedule it in the infusion clinic and that takes some time. So we've mostly been using the monthly preparations, and Sublocade is we've had at the hospital for much longer, so we have quite a few patients on that. The picture is of someone, so Sublocade's given into the abdomen, kind of in a square around your belly button, and you can see like his last 3 injection sites are still there. So Sublocade is in kind of a thick formulation. It goes right underneath the skin and then kind of makes these little balls. And that's what the medicine sits in that and slowly disperses over the month. So for some people, especially thinner females, they don't always like these because they are obvious and they do stay there. I think this gentleman said he was on dose 5 or 6, and you can still see kind of the last 3 that are still there. So that is probably I think people like Sublocade enough that they don't care too much, but it is kind of one of the downsides, and probably the biggest complaint is kind of the injection site reactions and then these kind of balls being there, especially if you have a nice abdomen like this guy. The difference on buprenorphine comes as a pill by itself, which we know is Subutex, but you can get it generically now. And then most of the other medications are what we call the combo product, which is buprenorphine and naloxone mixed together. And it sounds strange that we would put naloxone in this medication, which is Narcan, because it sounds like those 2 things would not jive well together. But when you take naloxone sublingually underneath your tongue, it's not, you don't absorb it enough that it's an active medication. Whereas if you took Suboxone and injected it, that would cause withdrawal symptoms. So really that naloxone has been put there as a deterrent for injecting it. It's not really there as part of the medication that's helpful for opioid use disorder. So there are some thoughts now that people get some side effects from taking naloxone sublingually. There's still some more research, I think, to be done in that area, but I do have some people that prefer just the plain buprenorphine because of that. Next slide. Oh, sorry, at the bottom, so there's lots of different ways to start buprenorphine. If you start reading about this, it becomes dizzying these days because everyone's studying different things. With the sublingual products, there are lots of different ways to do it. We kind of call it a low, traditional, or high dose inductions, and we're going to go over all of those really briefly. Brixadi, the injectable, you can start after 1 dose of sublingual buprenorphine. So there are some emergency rooms that will do this if people come in and they're in withdrawal and they can tolerate 1 dose of let's say Suboxone or Subutex in the ER, they could start them on Brixadi in theory. We're not quite to that level at our emergency department yet. In Sublocade injection, you can start after tolerating 1 week. So usually I would meet with someone, have them start on Suboxone for a week, and it allows us time to get the prior authorization for the insurance and set it up with the infusion clinic. And then hopefully by the next time they come back in a week or 2, we can get them on the Sublocade. Next slide, please. So this is just an example of what we pass out to patients that are trying to do what we call a low dose induction. So this is for someone who maybe is coming in, is actively using fentanyl. And the theory is that if we use a little baby dose and kind of build it up over a week of buprenorphine while they're still actively using the same amount of their opioid, that there will be less withdrawal symptoms. So I think it looks really nice on paper, and I think it's a really good theory, and I think it's really hard for someone to stick with this. We've done it successfully a few times. I think what happens most of the time, as you can see, you kind of go day 1 through 6 of using, oh my gosh. Sorry, my computer keeps going to sleep on me. Can you go back one more? So you continue to use, let's say, fentanyl for the first day 1 through 6. And I feel like when people get to the point of being here and they're ready to stop using, it's really hard to continue to do that for another week. And most people want to cut back on their fentanyl use at the same time, and that actually can make the withdrawal worse. So I think this is, good for the right person. We've done it successfully before. I just think it's sometimes really hard to do. And then basically you get to day 7, you stop using your other substance and you go to like a regular dose of 60 milligrams of Suboxone. It didn't print out really good on your guys' screen, but there are medications that we give for withdrawal symptoms because patients are going to have some withdrawal when doing this. Clonidine, I think, is very helpful for kind of that anxiety, kind of coming out of your skin feeling. We use Zofran for nausea sometimes, ibuprofen. Sometimes we use muscle relaxants and other things. So we definitely send people with kind of an arsenal of things to treat their withdrawal if they're starting this at home. Next slide, please. So this is what we call like more of a traditional buprenorphine induction. This is what our ER will be doing or has just started doing really in the past couple of weeks. And this is more the stop using whatever you're using, wait till you start to feel some withdrawal symptoms, and then start buprenorphine in hopes that there's enough, let's say, fentanyl coming off of your opioid receptors that if we put little bits of buprenorphine there, it will actually help with your withdrawal symptoms. So what you would do on day 1 is kind of take a half dose, wait an hour. If you're still feeling like you're having some withdrawal symptoms, take another dose, wait 6 hours, and you could take another half strip or half dose. And that would be the first day. So you're getting like 8 or 12 milligrams the first day. And then the next day you just go right to like a full dose. So I do find in the office more people just wanting to do this. For the most people that we see, this is not their first time around being on Suboxone. They know how their body reacts and feels to it. And most people know they can wait 12 hours or 18 hours, or if they're using a stronger fentanyl or some of the designer opioids, they might have to wait 24 hours, but they kind of can figure out that timing of when they can start the buprenorphine and not feel too bad. And again, we can always send them home with comfort sort of medications to get through any withdrawal symptoms they might have while they're doing this. So this is kind of what our ER protocol is based on, and we do this a lot in the outpatient office. Next slide. I just wanted to bring the CA Bridge to your attention. It's a website, it's free, and anyone can use it. It's based out of California, and they write a lot of patient education materials and a lot of protocols that we'll use in our hospital to write our own protocols. This is an example of like a high dose buprenorphine induction. And again, this is someone presenting maybe to the emergency department. You're determining whether they're in withdrawal or not, and if they're in withdrawal, really treating them aggressively with high dose buprenorphine. I like that this also has like prescription advice maybe for the ER to write and give to patients to try this at home. It also has the treatment for precipitated withdrawal within the protocol, which is always a concern for people now, especially using fentanyl and some of the stronger designer opioids. True precipitated withdrawal feels really terrible. It's a really abrupt onset of very severe withdrawal symptoms. I feel like people tell me that this happens a lot to them when really true precipitated withdrawal happens probably under 5% of the time. But certainly I think what people perceive is just bad withdrawal symptoms. They might be calling precipitated withdrawal. But this is just some guidelines about how to treat that. So this is not something we're using currently in our ER, but we might get there someday. Soon. Yeah. Next slide, please. So these were kind of some questions that we get a lot in the office. And what happens if someone's on buprenorphine and they're stable and then they have something happen, a car accident, or they're having an upcoming surgery. And we have done some work with our local surgeons about this because I get a lot of questions about it, and I get a lot of discrepancies about what providers tell patients to do around the time of surgery. So we offer to do pre-op planning for any of our patients. I have kind of a generic letter that I will send telling the provider that's doing the surgery what they should be doing with their buprenorphine. And we've agreed here that the surgeons will handle their acute post-op pain for 1 to 2 weeks. And if they're having difficulty, if it's my patient, they can send them back to me and I'll kind of take over at that point in time. But I think the biggest thing is to please keep taking your buprenorphine. Nothing is harder than controlling someone's pain who's also withdrawing from their buprenorphine. And I have had surgeons, even in the past year, tell people to stop taking it while they're taking their post-op opioids. And that's just old medicine, and we don't do that anymore. If they're on higher dose buprenorphine, like more than 16 milligrams a day, you may need to come down a little bit to 16 milligrams, only because if you need some post-op opioids for pain control, it's not going to be as effective if you're on a higher dose buprenorphine, because again, it's going to block those receptors. But it is certainly okay for people to take a couple of weeks of opioids to manage their post-op pain, just like we would do for any other individual that was having pain. It may not work as good, and I find that we usually need to use about 50% more. And obviously, if someone had some severe trauma, they might need to be hospitalized to treat their pain. There's lots of non-opioid medications that we try to use. We try to tell our surgeons to be really patient, that a lot of these patients may have some trauma and may have hyperalgesia, which is just meaning that you experience pain at a little bit higher level. And that's a common occurrence in anyone that's been on chronic opioids or chronic buprenorphine. We try to have them set expectations and just have good communication because that helps. And we certainly have people that are so fearful of even being on a few days of opioids that sometimes we just use the buprenorphine and increase their dose temporarily. And that works well for some minor procedures. So I find that just talking to people, and figuring out what they want to do and what their goals are works good. And then coming off of buprenorphine, like I said before, there's not really any specific length of time. It's what's right for the person. And some people may need to be on it chronically and forever. And that's definitely a different, different idea than when I started doing this 15 years ago. You can definitely slow wean by just slowly cutting back the dose. Sometimes that takes a really long time. I really think in the whole time I've been doing this, I've only had 1 or 2 people actually do that. It is really difficult due to some of the withdrawal symptoms that people can feel. We certainly have those same comfort medicines. So sometimes I have people just coming off that last little 1 or 2 milligrams. We will just pick a week that's good for them and try to give them meds to get through. I have had much more success having people switch to the monthly extended release injectable medications. I've only done this so far with Sublocade. Once you get 3 or 4 months worth of Sublocade in your system, if you stop it, it takes months to come out of your system. And I think I have a few people now that are like the 6 or 8 month window that are still testing positive for buprenorphine that haven't had Sublocade in 6 months. And for maybe the 6 people or so that we've tried this with, none of them have had withdrawal symptoms, and it's worked really, really well. So I think that it's a great, I like Sublocade up front for lots of reasons, but I also like it on the back end of people that are just really in a good place to come off of buprenorphine and want to do it without feeling terrible. I really think that you need to talk about the risk of overdose, especially if it's been someone that's been in treatment for 10 years. The drugs are way different, and someone not having buprenorphine in their system and using now compared to 10 years ago is really, really risky. And so, we do it when people are really in recovery and ready to be there. But I always tell them, if you feel anything, any cravings, any desire to use, to please get back in contact with us, and we're certainly happy to restart medications at any point in time. So next slide. I know. So I wanted to talk just a little bit about stigma. I think things have gotten better over the years, but there's certainly still a stigma for patients that are in treatment, especially getting medications. We get this a lot from the pharmacies, sometimes from our own emergency department, law enforcement, within our own hospital, from patients themselves. That's a self-stigma, and I put the definition there. So we kind of feel like our job running this program is to educate our community and our patients, and we've done a lot of work talking to our emergency room. We've made some flyers for our local pharmacists. we really just try to keep doing ongoing education about stigma. So everyone in primary care now gets, we have a Maine Health stigma video that all of our new staff watch, that all of our new MAs watch. People on the phone will watch. Is there anything else that you would want to say about them? No, I think we're covered there. Next slide, please. And this is just kind of a stigma tool that we will use anytime we give a presentation. We usually pass this out. And this is again from the CA Bridge. I really think it's a nice little handout. It probably prints out a little bit better if you printed it out at home, but it's easy to find on that CA Bridge website. So it's just about terminology and using terms that are more patient-centered and first language. And one more slide, because I know I'm getting close to my time. I just wanted to put in a little thing about harm reduction. We definitely do work in a harm reduction sort of model in our program. And that is just a set of strategies and ideas aimed at reducing negative consequences associated with drug use. And it is also a movement for social justice based on the belief and respect for people who use drugs. And there are many examples of how we do this, both in our office and nationwide. I think it has taken us, years to get to this, and some of these sometimes are a little bit hard for people to suggest or maybe wrap their heads around. But all of these things have good medical literature behind them, supporting that they either reduce risk to people that are using drugs, especially risks of HIV, hepatitis C, and usually keep people in treatment, which is our goal.
I think this harm reduction model has a lot of stigma behind it as well, in that we really do try to educate people on why we have a harm reduction model and what that means. Because years ago it was kind of taboo, people giving safe injections or needles. So we really try to educate, and we offer all those things here to anybody in the community that needs it.
Thank you. I think the next slide was our last slide.
All right. We now have a few minutes for Q&A. So feel free to unmute and ask a question, or if you feel more comfortable, you can put that question in the chat and I will make sure that, gets paid attention to. If you could raise your hand too, I'll just try to make sure we have a lot of people today. So I'll do my best to make sure everybody gets called on.
Hi, Meg, it's Cheryl. I can't raise my hand because I'm driving, but I just want to say thank you both for this was a great, informative, presentation about medication for opiate use disorder. And I one thing that really stuck out for me that I just loved hearing a doctor say, we just need to talk to them. And bless your heart for taking the time to talk to people who are, getting ready to have a surgery and have an addiction and, listening to what their needs are. And so I just really appreciate your whole approach, and what you presented here today was so informative and educational and really helpful. I thought I knew stuff about this, but I learned so much more today, and I can't wait to go to that CA Bridge website and pull some documents for my own organization down. So thank you very much.
Thanks, Cheryl.
That's it.
There is a question in the chat here from Melissa. Is COWS, COWS, still used to assess the patient's withdrawal?
We do still use that when they're, their initial appointments in the emergency rooms use this a lot. to see where the patient is in withdrawal.
And that's a term I'm not familiar with. Would you mind just saying what that is?
The clinical opioid withdrawal scale.
Yeah, it's basically like a symptom scoring scale, just like people might be familiar with CWA for alcohol withdrawal in the hospital. So it's basically a symptom score. And if you look at some of those CA bridge protocols, I think they say if you're like at an 8 or a 10, that's moderate withdrawal. And that's when you would want to start buprenorphine.
Awesome. Thank you. Lena.
Hi, wonderful presentation. Thank you for taking the time to go over this information today. I had a question. So like a decade ago, I have lived experience with trying to be on Suboxone. And one of the things I noticed was the process of getting on Suboxone. You had talked about like taking 4 milligrams and waiting 45 minutes and taking another 4 milligrams. In my experience, it was an awful experience. I was going through horrible withdrawals and I was stuck in an exam room that was cold in a hard chair. So I'm curious if at this point that medical professionals have addressed the comfort of going through that process at a medical facility, like a comfortable chair, a warm blanket, frequent check-ins. Can you talk about that process?
Sure. So, here we usually have people do inductions at home. So we're not doing in-office inductions just because I don't have the medication available on site to give. So usually what we're doing is talking to the patient, giving them instructions, picking one of those pathways, and then giving them prescriptions to go at home, and then just kind of frequent follow-up. Our emergency room literally just started a protocol for this 2 weeks ago. And so that is something that we will probably continue to work on with them.
That's good feedback though, because those are things that I can bring to them and try to, but we don't do detox, like we don't have a detox facility here. So that's why we do a lot of stuff at home.
Thank you. Any other questions? Oh, yes, Keith.
Hi, how are you? That was great. That was very informational and very good. I had a quick question. So what has been your experience or your experiences with people attempting to stop Suboxone, come off of it? How are they doing over the course of the next month? Is there anything being done for them during that period of time? It's just been my experience where that process can be pretty awful. So yeah, is there anything involving when you do decide to stop? Is there any medications like a comfort medication or, I don't know, therapy or something like that?
Yeah, definitely especially if it's been in someone in recovery for a little while and maybe they're not seeing a therapist anymore, I do encourage that as a time to kind of get back because it's just a different set of skills maybe that they're going to be needing. And like I said, coming off of the sublingual form is really, really hard. I've only had very few people do it very, very slowly. And we do use some comfort meds like clonidine and anti-nausea meds and maybe some muscle relaxants. But I have had the best luck with Sublocade and people just getting 3 or 4 months of injections and stopping. And then we still meet with them every month because they don't even really start decreasing their blood level of buprenorphine for about 8 weeks anyway. So they usually feel really pretty good the first 2 months, but then we make sure we keep meeting with them afterwards.
And the only symptom that I really hear people complain about or have complained is that they feel a little tired. And that's really the only complaint when they come off this Sublocade.
The Sublocade, yeah. I have also heard very good things about it. Yeah, okay.
Yes, therapy is definitely smart recovery, getting them more active and like in better coping skills, things like that, definitely.
Cool.
I do think that we didn't talk about it a ton because I was running short on time, but I was kind of asked, what like a peer support specialist role might be, with someone that you're talking to that's using MOED. And I think that just like knowing about all these different protocols and how, hard it is now. It used to be back that you could stop your oxycodone and take Suboxone the next day, everyone was happy. It worked so much easier. And now with fentanyl and some of these designer opioids, it's really hard to get on medications these days. And I think if you're working with someone that's starting this process, maybe asking those questions, or even being a liaison to their provider and saying, gosh, this person's really struggling still, or maybe some comfort meds might be helpful. But I think just knowing about this process and maybe being a support person through, both the front end of getting on meds and maybe at the other end coming off.
Hi, this is Cheryl again. Just to follow up to that question, as someone is coming off, even with the Sublocade, my son did that and it did work just like you said. Those little balls in his belly, like, released it for months and he successfully got off. But like, typically, like, how long is that process? Does it matter how long you've been on it, or is it always like 12 weeks or 14 weeks? Like, how is that? Like, how long would someone potentially need comfort beds or need monitoring or something? Like,
yes. So specifically with Sublocade, it takes about 4 or 5 months to build a steady state in your system. I have had people do it after 3 months and be okay, but I've had people also try to stop after 3 months and it probably doesn't last in your system quite as long. So the drug company does recommend at least like 4 or 5 months to reach that really steady state in your system and then stopping it. And like I said, I only have 6 patients maybe that have done this, so it's not a huge group, but I haven't had any of them have any withdrawal symptoms except some fatigue, and no one has had to use any comfort meds. But you could definitely do that if they were having any of those symptoms: Clonidine, nausea meds, muscle relaxants. But I haven't had to do that with Sublocade.
that's awesome. 6 people is 6 people. Like, that's great, right? So thank you.
If there are no more questions, we can turn it over to Troy. And if you do have questions, that pop up and while we're listening to Troy's presentation, please feel free to write them down, hold them in your head, and we will have another Q&A session at the end.
Okay, hi guys. So thank you again, Dr. Smith and Angelique. That was awesome. Lots of great information there, and I thought I was going to kind of balance that out a little bit and give you a little bit of some life experience stories. I am 7 years in recovery, and I've had a relationship with Suboxone for probably 15 years. Not always prescribed, going on and off through active addiction and through recovery. So I've had a lot of different experiences with it, and I've seen a lot of the attitudes and policies change. So I kind of want to just put a little bit of perspective onto that. And you may be wondering why I'm still on Suboxone. I definitely consider myself stable in recovery. I work in peer support, but hopefully that I will address that by the end of this. So moving along. So to be able to understand the current state of addiction medicine, you must also understand the opioid epidemic. The effect it has had on our society, judicial, and healthcare systems is massive. Its significance cannot be overstated. So this is a training on addiction medicine, but I thought it was kind of important to also give some focus onto the opioid epidemic and kind of zoom out a little bit, because I think to really understand why it has the place it does, we really kind of have to understand the context of the opioid epidemic. Over the past few decades, it seems like there's one crazy world event after another, whether it's wars or once in a century pandemics. And I think it's kind of it's easy to like lose focus, or it's almost like information overload, and we kind of forget how significant these past 20 years have been with this opioid epidemic, and how much it has changed and how quickly it has changed. So I present to you my experience of the past 25 years. It is the story of how I survived the opioid epidemic, going from active addiction to recovery. Sorry. Suboxone saved my life. Please remember that my story is unique to me. What worked for me may not be the best for everyone. There are many paths to recovery. And I'd also like to add on to that this is not just a story of Suboxone, but also a story of Narcan, because Narcan definitely saved my life more than once. So I'm not going to focus too much on this, but I will give a brief timeline of the opioid epidemic. Opioid-involved deaths have increased substantially since 1999. I believe the milestone we're at now is over 1 million deaths between 1999 and 2000. Opioid overdose-related deaths. Now, there's 3 distinct phases involving 3 different substances, which I think is kind of important to understand. And as you'll see in my story, I definitely rode each one of those phases. So the first wave started in the late 90s and involved the abuse of narcotic pain medication stemming from the wide overprescribing by doctors. The second wave started in 2010 and involved a spike in heroin use. People often developed an addiction to prescription narcotics and moved on to heroin. And this is kind of when there was a national spotlight kind of being shown on all of this. And almost like a classic story, and this happened to me. People, well, I wasn't prescribed them, but people got themselves addicted to these narcotic medications. Then all of a sudden, the access was shut off, or they had to get them from the street, and it was super expensive. And all of a sudden, heroin was there in more of an abundance than it had been, and it was cheaper. So we had this very short-lived heroin epidemic. But then that moved into the third wave, which started in 2013 and continues to this day. Illicit manufactured fentanyl smuggled into the US flooded the country. The opioid epidemic has now become an overdose epidemic. Next slide, please. So this is a chart from the CDC, and you can kind of see here that first line in black, that's just the opioids in general. It looks like the purple there would be the fentanyl, and you can see right in 2013, it just skyrocketed. The line above that would be like the Oxycontin, and then you can see that little bump in heroin there. So that's just kind of something to keep in mind. Again, this is kind of just for context. And next slide. Okay, so I broke this up into 3 chapters. I promise it won't be that long though. So chapter 1, I named The Early Days, Playing with Fire. And this is about both my own experience, and I named it this because it's kind of a reflection of where we were at in our society, this kind of naivete, if you will. I heard reports of doctors actually being shocked at the beginning of the opioid epidemic, because in the 90s, they were taught in medical school, that things like Oxycontin had no abuse potential. And of course, we know in hindsight that it wasn't all naivety. Prescription or pharmaceutical companies like Purdue Pharma have ended up paying billions and billions of dollars, and the Sackler family. So it became, not a conspiracy, but I'm going to move on. I'm sorry. So anyway, we're going to go on to my experience. So I'm starting this in 1999 and moving through 2008. So I graduated high school in 1999 and first started college. And with me, these were kind of the first signs of substance abuse and addiction. In high school and college, I partied and experimented, but unlike today, heroin and needles there was this element of it being taboo, almost this like mystique around it. And a lot of that had to do with pop culture. I can think of two movies off the top of my head: Train Spotting from 1996, Requiem from a Dream from 2000, and musical icons Kurt Cobain, Jerry Garcia of the Grateful Dead, and Trey Anastasio of Fish. In college, I saw the band Fish dozens and dozens of times. Every summer, I would travel the country, going on tour with them. And Trey, who is the lead guitarist and kind of the front man of this group, he's actually in recovery now. I believe he got arrested in 2005 with like basically a pharmacy in his car. He was addicted to Oxycontin, and I remember we kind of like watched this addiction develop in real time. This band was known for these like amazing live performances, and I remember the first time Fish played a bad show. It was almost like this, like, you know, like breaking up with a loved one or someone. You know, Trey would come out and he'd just be clearly on drugs, sometimes doing drugs on stage, falling all over himself. So that was kind of like my first exposure to this. So at my senior year of college, I dropped out and I moved out to San Francisco. Out there, I started experimenting with heroin and methamphetamine. And you hear these stories of when people first encounter their their drug of choice that they become addicted to, that it's like, you know, almost like love at first sight. And for me, that was black tar heroin that I first did out in California. It's kind of more of like a West Coast phenomenon. There's not it's powdered heroin when it was around, was out here. Now it's of course fentanyl. So out there, I overdosed and had a really awful experience on meth, and I ended up moving back here. And I went sober for 3 years after that. I developed PTSD, and the meth brought out all these psychological issues. I couldn't leave my house for like 6 months. But I did go back to college for about a semester, and this kind of shows me how fast things were changing at this point. So this was, I think, 2004, and a really good friend of mine died of an overdose, of a methadone overdose. He was 21, and he was drinking at a party. He wasn't, you know, none of us had like actual drug habits. It was just one of these things that, you know, pills came. I believe they're methadone wafers back in the day. You know, back then we just called them Farmies. You know, and it was just partying, and you just kind of like, you know, something to do. And this is again where things really kind of started to turn dark. So at another point with the methadone too, 20 years later, I kind of still had a bias regarding methadone, and I believe it came stemming from my friend overdosing and dying on this. And actually, the first time I met Dr. Smith and Angelique was over a year ago through my work at White Horse Recovery. And I remember expressing something along the lines of like, you know, why would anyone, take methadone? And Jen kind of schooled me about, you know, that it's, you know, the path is completely valid for certain people, especially people pregnant. So it's just kind of a note that I held this bias. And also methadone too. I believe it was in 1974 is when it was first allowed to be used as a treatment for opiate use, and that's when kind of the clinical framework kind of developed, where people had to go to the clinic and get their dose every day. And back then, it was almost always exclusively in inner cities. So methadone, it was well, at first it was, and I'm sure continuing to this day, there was kind of the stigma related to it with, you know, these dirty homeless people, you know, urban. I remember reading an article, I believe still in high school, so this would have been the late 80s, of a proposed methadone clinic in North Conway, and it didn't go. People were just up in arms, you know, the classic, oh, we don't want those, you know, those people in our backyards. And this is before the opioid epidemic. So we'll move along though. Next slide. Okay, so chapter 2, In Too Deep. So this is when things started to get serious for me. as I said, I was sober for 3 years. I was deeply involved in Buddhism. I stayed at a Buddhist monastery for a while. And eventually I just started drinking and partying again. Now, at this time, this is when the opioid epidemic was kind of like in full effect. The OC 80s, the Oxycontin 80s, that was kind of the big thing back then. And it was interesting. I remember like almost overnight there was like this new class of drug dealer that came about, where it was like, you know, these older like women who realized they could make like $3,000 a week, and you know, by opening up their medicine cabinet, and we were buying pills and stuff from just people you would never think or associate would have a drug addiction were either selling these pills or on these pills. And this is when kind of the media started picking up on this, because, you know, all of a sudden it was affecting rural areas or in rich white suburban kids. So things were really starting to pick up at this point. So 2009, I started to develop an addiction to Oxycontin, and then I moved on to heroin. And this is right around the time when Suboxone entered my life. In fact, the first time I actually took Suboxone, I took it recreationally. I had no idea what it was. I'd been drinking all night at the bar, and at some after parties, somebody had like 3 of these stop sign big pills, and I was extremely intoxicated, and I ended up doing a lot of Suboxone, and I got sick for probably like 3 days. I ended up losing a job because I was in very, very, very bad shape. And this was also before I had actually developed a habit. And Suboxone is kind of, this goes back to kind of the science of it being a HAP agonist. It's one of these drugs where it's going to affect people very differently. If you don't have an opioid addiction, it's going to make you incredibly ill. I mean, it may get you high, but it's going to be very, very bad for you. But then again, if you do have an opioid addiction, it's either not going to do anything, or if you're in active use, it's going to put you into withdrawals. And I will say something about precipitated withdrawals. I'm glad this came up. It was interesting in the previous presentation that Dr. Smith said that less than 5% of people actually have true precipitated withdrawals, right? Because no matter what, if you go from like fentanyl to Suboxone, you're going to feel withdrawals. So that's another thing that should be addressed. It's no small feat going from fentanyl to Suboxone. Like it's a big leap. And I remember even under the best conditions, it would take me at least a week to get through these initial withdrawals. But as Jen was saying, that this isn't true precipitated withdrawals. The first time I had true precipitated withdrawals, I had just started using needles, which was really kind of the last boundary for me. Things just fell apart extremely quickly. And I had been doing heroin, or probably fentanyl at this point. I can't remember exactly when this was, but I did my last dose maybe like 2 a.m, and I had to go to work the next morning. And so it had been like 5 hours since I had used IV heroin, and I had some Suboxone on me. I'm like, oh, I heard you can, you know, shoot these. So I went into the bathroom and I IV'd a full Suboxone, and I thought I was gonna die. It was like no withdrawal I had actually ever experienced before. And like she was saying, it was instant. And one of the more frightening, I've overdosed on countless times, and it was actually one of the most frightening experiences on drugs I've ever had in my life. So yeah, it's a pretty serious thing. So at this point, very few doctors would prescribe Suboxone. In North Conway, where I lived, there was one doctor that would prescribe it, and you actually had to write an essay in order to get even considered for this. So I ended up going to Portland. It was almost like a 2-hour drive not like methadone where you had to go, once a day. It first started as once a week and once a month. And at first, at this point, I was still using too, right? And so I'm getting a little ahead of myself, but so when I first started taking Suboxone, whether it was off the street or through a doctor, initially it was kind of used to like just not feel bad, right? For withdrawal symptoms. But it got to a point where that really couldn't happen because I would take the Suboxone and I would go into withdrawal. So there really does come a point where it's one or the other. Um, I've heard some people having this misconception that somebody could just use fentanyl all month and then take Suboxone, the day of their appointment and be good. But it does not work like that at all. So around this time, I did get arrested. I made the news for having a meth lab. I think this was in 2012. And I went to prison. And I'll give a little side note about prison at this point. Now, I think within the past 4 years, I'm pretty sure every county jail in New Hampshire and the New Hampshire state prisons actually have an addiction treatment program. At first, it was if you came in with a prescription of Suboxone, you were allowed to continue that prescription. And I believe now they actually have a program where you can sign up and get it prescribed. It's a whole program that they have within the prison. That did not exist when I was there. And so both in prison and out of prison, there was kind of this gap, right? This gap from not having the treatment available. And the black market, as often happens, kind of moved in to fill that gap. And in prison, Suboxone would literally go for $200 to $400 for one dose, one strip. That's a lot of ramen noodles, and it became a huge issue. I went into prison. I got clean before I went in. I left prison with a habit. I was doing both heroin and fentanyl and Suboxone. So next slide, though, please. Yeah. Okay. So chapter 3, the road to recovery. Again, everybody has their own path to recovery. Mine has a UFO, as you can see, but we're past that now. So my experience. So 2000. This is more like 2015. I got out of prison in 2015. So 2015 to the present. My recovery had many rough starts, as is often the case. When I first got out of prison, the fentanyl phase of the opioid epidemic was in full swing. The first time I used, I overdosed. So I got on a Suboxone program, and this is kind of the phase of my story where I was like, from this point out, I was kind of steadily on a Suboxone program. And what was different about, at least for me, back in like 2015 on these programs, there wasn't much difference between going to the doctor and getting Suboxone
Hi
and
there. Just a minute. Yeah.
okay, and going to like it felt like going to like a parole officer. I mean, I say this often, but they would literally kick you off the program if they didn't like the color of your shirt. There was this huge power differential. They had rules like, if they called you and your voicemail wasn't set up, they would kick you off the program. Um, they would call you randomly and you had 24 hours regardless of what you were doing and where you were to go into the office so they could do a pill count. So it's very different than it was today because you had this constant threat of getting kicked off. And so yeah, that kind of brings me to this next point of how important it is to find a provider that works for you. I currently get my prescription at a healthcare center in Maine. Sakapi Health Center, and it's a wonderful place. About 4 years ago, I switched providers, and I was having issues with my last provider over urine tests. And at this point, I had been clean for 2 3 years, and out of nowhere, I started getting these false positives, dirty urines for like these trace amounts of like oxymorphone, some like random opioid, and it happened like 3 months in a row, and they would of course punish me for it. And it got to the point where there was actually a local like doctor, just like my normal PCP, and before my Suboxone appointments, I would go and get urine tested there the same day. So I would have these two separate urine tests, one showing that I was clean, one showing that I was dirty, and they just punished me more for that, for doing that. Like they literally had it was written into their policy where if there was any discrepancy, that you are automatically considered to be a liar. And and they also said that, written into their policy, that false positives are scientifically impossible, which is not true. So that's just a little side note there. And again, I think things have changed quite a bit. Now we're kind of more on a harm reduction model, and the doctors aren't looking to kick you off. So another story I'd like to kind of share is I did have to stop taking Suboxone cold turkey. I was about 6 months, a year clean. 2016, I think this was. I moved out to Bangor, and just the situation, I can't remember the details of it, but I had to stop cold turkey. And I just started a job. And I was on a full dose. I was taking 16 milligrams a day, and I did. It was awful. It was awful. But what happened was, about like 3 months into it, I felt like I started getting this little like ticking thing going off in my head, and I knew I was going to relapse. And I started buying Suboxone off the street, and that kind of habit, I met dealers, and eventually I did relapse. And again, the first time I used fentanyl, I overdosed. And this is a story where the naloxone kind of comes into play. One of the many times Narcan saved my life. So this is my first time using in a year. I was up in Bangor. I just met some kid randomly on the street, and you got drugs? I was buying drugs from him, right? And so we went upstairs to my apartment, and IV using, and we both took a shot, and I immediately overdosed. And he was like, "Okay, I'm out of here." And he was walking down the stairs out of my apartment, and he just randomly ran into somebody that he knew, and he was like, "Hey, do you have Narcan by any chance?" And the guy was like, "Yeah." And he was like, "Oh, there's a guy overdosed up there." So this complete stranger walked into my apartment and gave me Narcan, and I'm here to tell about it today. So that the availability of naloxone, Narcan, is played a huge role in kind of like curbing the opioid epidemic. The years 2014 to 2017 were very dark years for New Hampshire. We were the second worst in the country for opioid related deaths, behind only West Virginia. The data is kind of conflicting, but we're doing much better now, and a lot of that has to do with legislation that made it easier for practitioners to prescribe Suboxone. There used to be this waiver; it was called a data waiver that had to be you had to apply for, and both both Obama, Trump, and the Biden administration have passed legislation progressively making it easier for folks. And the government of New Hampshire did a lot of good things with making these treatments more available, with both Suboxone and Narcan. I know Littleton you may have seen them. I think they're called nalox boxes. They're actually vending machines where you can get Narcan 24 hours a day. So things have changed a lot. another story I will share with you about kind of why I continue to take Suboxone. Um, for me, it is kind of part of an overall part of like my mental health treatment. When I got clean, I had a lot of things to deal with. My meth use left me with severe PTSD. I have severe OCD. So it kind of gave me room to deal with these other things without having to like worry about cravings all the time. And the biggest thing it really helped me with was with impulsivity. I remember I was working in a store, and this was like within a year of getting clean, and it was Christmas Eve, and just this random person, it was like 5 in the morning. This random person came in and was like, "Hey, Merry Christmas," and he gave me like a half gram of fentanyl, and I was like, "Huh, wow." And I thought about it for a second, but I knew if I used it, it wouldn't do anything, you know. And I've tried this before. I wasted a lot of money over the years being on Suboxone, trying to get high of opiates, and it blocks it. It does its job quite well. So I knew that in order to use this, I would literally have to like plan out, you know, stop taking it for 3 or 4 days, get sick. So it really, you know, almost all my relapses in the past had a degree of impulse to it. So being on Suboxone really kind of like has taken that out of the equation. Um, so that is a huge thing. And for me personally, you know, I think Dr. Smith did a really good job of being honest about this. I know when I first, like the first few doctors, you know, 10 years ago that I saw that would prescribe Suboxone, they would say like, "Oh no, you won't withdraw from this. There's no withdrawal." Like I've actually heard doctors say that. It's crazy. So it's nice to hear a professional be honest about this stuff. You know, so there are you know, it's a cost benefit analysis, as we say in smart recovery. For me, the benefits far outweigh the costs. I go to my doctor once a month. I would be going there anyway because I go for my therapist is there, you know, for my other mental health medication. So for me personally, it has worked wonders. Don't feel like I don't feel like any less in recovery than I would be if I wasn't taking this medication. It's just another mental health medication for me. So,
And Troy, I'd like to really thank you, but we're running out of time,
okay.
kid.
Well, yeah, next slide.
And
It's the last one. So,
I okay, yeah. So we have to have time for
yep.
Q&A and surveys. So thank you, though. Go ahead,
Thank you.
finish. Yep.
That's it. That's it. I just want to show the alien doing the dabs. That's it.
Oh, you got to have that, right?
Yeah.
So
Yeah. Thank you.
thank you so much for sharing your personal
Yeah. So, yeah.
experience
Please,
on this.
if any questions, yeah, please.
Very much appreciate you and your lived experience and what you've been through, and so glad you're part of our Recovery Community Center network of peer support workers.
Cheers.
Go ahead, Mag, take it away.
Right. Awesome. Thank you so much, Troy. Just as we did before, if you can use the buttons, react buttons to raise your hand for any questions, and I will try to make sure everyone gets called on. Yeah, Keith.
Hi again. That was great, Troy. Thank you. Good. That was a good story. Thank you. I had just another question for maybe the doctors or Troy. If you guys consider Suboxone to be a psychoactive substance, you know, obviously meaning that it's having some sort of effect on how you feel, whether it's quelling anxiety, making you feel a little bit better than you would feel were you not on it. And I'm talking about long term, like let's say you're 2 years into taking Suboxone, are you still being medicated, comforted, you know, in some
Um,
way?
yeah, I hear what you're saying, and it's literally like taking a vitamin for me. I mean, sometimes I forget my dose, and I'll know at like the end of the day that I haven't taken it because I'm kind of like starting to feel weird. But no, like I don't get like a buzz or a lift or anything like that. It's really just kind of keeping my brain in a level of stasis, like if that makes any sense. And also, I'm on ADHD meds, and I have other medications where I would probably feel worse not taking them than I would the Suboxone. I mean, my cup of coffee that I have in the morning, I have more immediate effect off that. The Suboxone, now, the Suboxone doesn't. It just tastes bad. That's all. Yeah. So I don't know if Dr. Smith wants to add to that, but yeah.
Thank you. Any other questions?
Hi. I
Oh,
was thank you so much, Troy, for your presentation. I would really like to ask if you would care to share about how it feels working in recovery, being in recovery, and then still experiencing some stigma around your medication use.
Great
Um,
question.
I I really, I mean, nothing so much that it like I don't really like think about it so much, and I don't encounter it every day. And my job is more about other people, right? So um, it's more of like a like a I guess like a positive than a negative, I guess, because I feel like I can like relate more to other people, and yeah, I do encounter that, but that kind of, there's a lot of things have changing so fast, right? Like harm reduction. Everyone has like an opinion over harm reduction. I mean that like I just don't take things like that personally, I guess I could say. So
Thank you. Oh, yes, Rick.
Hi, I have several participants that are using MAT protocols. The one thing that has come up, and this may be more for the doctors, uh, a lot of the opioids that they're finding have xylazine. Is there any kind of protocol yet for xylazine of any type?
Not that I'm aware of. So xylazine is more of a tranquilizer. It's not an opioid. So Suboxone or methadone don't really do, and Narcan don't really do anything either to treat or reverse xylazine. But I would say we see it in probably at least a third of our patients that use fentanyl because we can test for it now.
But we do bring it to their attention that it's in their urine. We give them test strips because it isn't like Narcan's not going to work.
We do have like a patient handout about it, and also do like some wound care for patients that are starting to get some of the xylazine wounds. And sometimes going from injecting it to smoking it can be helpful for some of the skin problems with xylazine.
Thank you.
I guess probably also what I was asking was for detoxing with xylazine there as well. Is there anything to help with? Because I've had one that's got off of it, and they said it was hard to get. The withdrawal was so much different.
Yeah, I think it's really hard to sort out when people are withdrawing now, because I would say most of my newer patients that are using fentanyl that also have xylazine are also using meth and or cocaine or some other sort of stimulant. And so when they're withdrawing, if they're withdrawing from everything, it's so hard to figure out. I think it's harder overall. I don't know if it's exactly the xylazine or if it's just that everything is stronger now and there tends to be more things mixed together. I don't know of any research that shows that any of our comfort meds are helpful for xylazine withdrawal, but I would think that they would all kind of help with all of the different drugs, but yeah, haven't seen anything specific for that yet.
Right. Is there any other questions before we move on to our last bit of housekeeping? Okay, if that is all of our questions, I am going to turn it over to Danny to close us out and talk about the evaluations. Thanks so much, everyone.
Thank you, Maggie, and thank you all for joining our session. And before we wrap up, as mentioned, I'd like to share a few final reminders and acknowledgements. First of all, a heartfelt thank you to today's presenters for their valuable insights and also the sharing personal story that truly brought depth to the presentation today. Also, thank all of the participants, great questions and great participation overall. As you can see on the shared screen, we invite you to visit nhtac.org. In addition to accessing a whole wide range of resources and technical assistance, you'll find a recording of today's session and previous recordings as well. It's a great place to continue learning and connecting. Also, we're posting in the chat the evaluation link. Your feedback is crucial for improving future sessions. If you can use that link, you can also use the QR code that is on your screen. We appreciate if you please take a few moments to complete the evaluation form. And the final reminder for those seeking the CEUs, completing the evaluation is required. That's why we post the link there. Be sure to include your full name on the evaluation form to ensure we can issue your certificate. Thanks again for being a part of today's.
Hey, Danny, I'm sorry. This is Cheryl. I just clicked on that evaluation link and it didn't seem to work. So could somebody verify that before we?
Yeah, I just did too, and it doesn't work.
So we need a different link or we'll have to email it to everyone.
Can you give me just 1 minute
Sure.
to go into the folder?
Danny, if you pull that slide back up, I believe the correct link is on the slide, and I can transpose that into the chat for everyone.
That was the link. That was the link, Paul. Remember, it changed because the date changed. Remember, like Mana had the date. It was a different date. So let me just bear with me as I get into the folders and see what I can pull up. And then, Paul, do you see it on which, are you able to copy it from the, yeah, okay.
I just
try
posted
that
it in the chat. Just posted
okay, let's see if that works.
Yeah, I just clicked it and it works. Sorry for
Perfect.
there.
Thank you all for that quick fix.
No, great. Thank you for bringing it up.
Thank you all. Have a wonderful day, and we look forward to seeing you on our next event.